My name is Frederico Balzola. This is Turin. This is my hospital. I'm here in Turin. We are in a big emergency now. But in any case, as you told, I'm focusing on autism in the last 15, 20 years. And so my presentation will focus on our experience in Turin on intestinal problems in autistic patients. So from a clinical point of view, we know that human evolution and technology are running very, very fast. But even changing of clinical presentation of many inflammatory bowel disease have been seen. I mean, in my experience, an acute toxic megacolon that was normally used to see at the first aid, as you see on the left, is something that normally today is very, very rare. So now the same inflammation has a different way to be shown. I mean, more chronic abdominal pain, abdominal distension, and constipation are symptoms very common, the same kind of patient, and are now seen in the outpatient clinic less than the first aid. And for example, other autoimmune disease like the celiac disease, that in the past they had a presentation like this with malabsorption, diarrhea. Today, the presentation of celiac disease is completely different. You can see overweight patient, constipation, skin problem, infertility, and many of different symptoms that are apparently less related with the disease that we are used to see in the past. As well as the number of patients. For example, Donald, that was the first single canners patient presented in the past. Now we are facing a huge number of the same patient altogether. That means that something has been changed. This paper of the New England Medicine published in 2002 was showing an important changing in what we are now facing. I mean, how infective disease they were decreasing, and how many inflammatory, chronic, non-infective inflammatory disease were coming out, were increasing in number of patients. And this kind of presentation of the clinical aspects of many inflammatory diseases was also seen in allergy and in Crohn's and ulcerative colitis disease. And celiac disease as well has been changing in terms of number of patients during the years. That means that something is going to change, something that we don't know exactly why, but we see in the practical clinic. And for the same problem is the epidemic of autism and schizophrenia as a part of the trend of not infected chronic inflammatory disease. The answer is very complicated. Even if we think how is the pattern of the autistic patients, not only for the medical emergency, but even for the economical and social impact that they have. So that means that we have to be prepared and to better understand this kind of problem that are growing up very quickly in many, many, many countries of the world. And if we see this changing that is lasting the last 50 years compared to millions where the human being was quite similar, that means that we are not seeing a changing of DNA, but probably a change of DNA expression due for the environmental changing in terms of food, kind of life, antibiotics, and so on. Many things that are probably able to impact dramatically with the expression of new genes. If we go back on the prevalence of gastrointestinal symptoms in autistic patients, you see the range 15, 19% of patients with gastrointestinal symptoms is very important. And the range was probably due to the difference and enrolled approach that they use for the kind of patient. For example, different age or different neuropsychiatric diagnosis. But even for many patients, we have to say that many patients have a pain threshold elevated, and so it's difficult to understand where they really have pain. And even because they have a verbal problem, a verbal communication problem. But in any case, the literature is underlying why, how the symptoms, gastrointestinal symptoms, can interfere with the autistic behavior. And that's, I think, is an important problem to say, because for many years, the correlation between autism and pain and behavior was not considered. If we go back in the past, even Kanner described gastrointestinal symptoms and nutritional symptoms in patients with autism. And even Asperger was able to underline severe psychological problems in a young patient with celiac disease. That means that interaction between bowel and behavior was already seen in the past. But now we are changing. Literature is now showing us that autism can be shared in or categorized in two different aspects: a pro-inflammatory category or a non-inflammatory group. That means that as soon as we are able to find a patient with autism inflammation, the treatment of inflammation is crucial and is very important to achieve important results in terms of gastrointestinal symptoms and behavioral symptoms. So when we see this frog, we can say, is he relaxing or is he having a tummy ache? Because it's the perspective we have to change watching or staring in front of this kind of patient, because this is the normal way a normal child, not autistic, is showing the pain, while patient with autism is showing the pain a different way, with the pressure of the tummy, all positions that are able to reduce the pain. But if we see a patient with a pathological stomach distension like this one, and we perform an X-ray, we can prove how the disease is not only a disease of the brain, but is even a disease of the intestine. As well, the way they try to poo, because their rectal dysfunction, their tenesmus, their constipation with enormous stool dimension, that has to be to poo in a different position. That's very common in this kind of patients. And when we perform an X-ray, we can see how the rectum is distended, how many feces are inside there. And this is the reason of the hyperactivity or many kind of the pain that these patients are trying to say with the behavior. Even autostimulation is an antalgic behavior for the rectal pain. And when they got reflux, they have sleep disturbance or bumping the head. These are all symptoms that are rarely underlined by the neuropsychiatric. And the reflux is not treated. A lot of time become achalasia that you see is an anatomic changing of the esophagus. And imagine the difficulty to manage at the first aid when a patient is going there with pain. Sedation or contain of the patient is the only way to sort out the problem. It's very difficult to think that the symptoms were pain, just pain. Malabsorption, kind of feces completely pathological with starch and lipids. A lot of time these pictures are taken by mother to the GP to show how the son is going to the toilet. So from 2002, we made an outpatient clinic in our hospital with the collaboration with the neuropsychiatric department. And we followed more than 1,500 patients so far. Among these patients, we selected a group of 339 autistic patients for their major gastrointestinal symptoms. And so we performed a study that permitted us to see how was the intestine with the upper and lower endoscopy. You see they were 83% male and 70% female with the mean age of 9 years of age with a range of 2 and 45 years of age. The symptoms, the gastrointestinal symptoms were constipation in 48%, diarrhea in the 40%, abdominal pain 75%, macroscopic malabsorption 46%, proctalgia tenesmus 24%, food selectivity or hyporexia 20%, and reflux in the 35%. Going through the laboratory examination, a fecal occult blood positivity was present in 37%, fecal calprotectin positive in 41%, serological screening for celiac disease was negative in nearly 89%, and the sonography of the intestine was able to show lymphadenitis in 28% of patients, a thickness of the terminal ileum or the colon in the 9%, and the presence of fluid between the intestinal loops in the 39%. So 339 patients underwent lower and upper endoscopy with biopsy, and the results that we have in the microscopic examination, in the esophagus, we found esophagitis in the 51% of patients. In eosinophilic gastritis, the 4% of patients, lymphocytic gastritis in 3% of patients, and duodenal atrophy was less than 1%, where MASH1 or MASH2 inflammation of the duodenum was present in the 43% of patients. In the ileum, we found a pathological lymphoid nodular hyperplasia in the 66% of patients, a chronic inflammation with an infiltration of eosinophils in the 93%, so almost nearly all the patients, with an active inflammation in the 46%, and a chronic inflammation on the rectum in the 84% of the patients. So we have shown that there was an inflammation and was not a mucosal inflammation, was an infiltration of the layer, the submucosal and mucosal. And this data confirmed the previous published data that were in literature by these authors. So we tried to treat the inflammation with a food map diet and the IBD, inflammatory bowel disease therapy, according to the histological site of inflammation. The clinical result that we had were on gastrointestinal symptoms after drug and exclusion diet therapy, that the constipation was reduced, the abdominal pain was reduced, and the proctalgia and tenesmus were reduced. On the other hand, the neuropsychiatric evaluation after the drug and the diet showed a global improvement in a statistical and significant number of patients. In detail, hyperactivity was reduced, the motor skills were improved, mental attention was improved, and imitation was improved. So these data were able to show us that if you have an inflammation, if you treat the inflammation, you get improvement in gastrointestinal symptoms, but even in neuropsychiatric symptoms. In a recent paper that we have published, we show how a prevalence of duodenal histological inflammation was not linked to celiac disease. That means that these patients are not celiac. Benefit of the reduction of the food mass was achieved even if it was not a rigorous exclusion diet. And the alteration of the duodenal histology, but not the HLA-DQ status, was associated with clinical response to the food map diet. So this is Turin, this is the fog, this is the Mola Antonelliana, these are our mountains. What we have underneath, what we can see under the fog. why food changing and drug therapy could change gastrointestinal symptoms and even behavioral aspects. Many papers in the past were showing how in autistic patients there was an increase of intestinal permeability. These are the autistic patients. The patient underwent a gluten casein-free diet. You can see how the pathological permeability was reduced. As well as many papers in the past were showing how food and neuroinflammation were absolutely linked. So to understand why there were this kind of the interaction in this disease, I think it is necessary to go back to the origin to evaluate the environment changing and the human evolution. If we think how we were in the past for millions of years, we were hunter, so small group of people able to eat just this special and kind of food, while in the last 10,000 years, we changed so much in the way we are able to eat the food. So we became farmer, we were able to get with the agriculture a lot of food, we were able to make village, city. And so the evolution that lasts just 400 of generation is very close to us compared the million of years where humans were used to eating in a different way. Even the changing of the agriculture is changing the amount of food we are able to have. Harvest type of grains became very different from the past so far. Improvements of grain production contain more gluten by many agronomists like Strampelli, that was an Italian one, were all conditioned that they change not only the amount of food, but even the kind of food we are eating. And even gliadin, that was a kind of...
Should I go anywhere?
Sorry? It was part of gluten and has been shown many different action, and probably its impact in our intestine is due more to the amount of gluten we are now introducing. And even the changing of many conditions, for example, the increase of bacteria exposure that it was in the past, in the very early age for children, has been completely changed in our time, where hygiene and cleaning are just the way the child is facing for the first years of age. And so the changing of food and way to live change the bacteria exposure, and so can induce change in microbiota balance that was stable for millions of years. And this alteration could interact with the immune system and development of the immune system and problem with the brain. If we think how diet can change the bowel mucus, so there is interaction between an high fiber diet and the mucus layer. You see, it is very thick, and if we change our diet with more gluten, with milk and high fat diet, the mucus layer decrease immediately, and different kind of bacteria were there on the mucosa. That means the diet directly and very rapidly change our state of the intestine. And so what Hippocrates says in the past, where all begins in the intestinal, what's happened in the intestines never remains in the bowel, said Alessio Fasano in 2010. That means that Fasano, that studied the roots of the beginning of the interaction between intestine and immune system for celiac disease, and he discovered the zonulin and discovered the crucial role of the zonulin in celiac disease. And that zonulin, you know, is a protein, is the mutation of the haptoglobin that changed just in humans 2 million of years ago. and his direct action is on the tight junction. So zonulin is able to open the tight junction on the intestine. That in the past, probably 2 million years ago, was a way to make a step, an important step for human evolution, to make much better and rapid communication between the environment and the immune system. But now, zonulin, probably due to the change in the environment, has been associated with many inflammatory diseases. And if zonulin has been shown in many diseases, many patients of autism has been shown increased serum zonulin levels, as in this paper that I show. As well, this patient show an increase of pro-inflammatory cytokines. That means that if zonulin and inflammatory cytokines increase in an autistic patient, we can also see a less anti-inflammatory cytokines. That means that this patient have an inflammation, and if this inflammation is there, that means that we have to change the way to treatment. If we have, going back to autism, an increase on inflammatory cytokines, as was shown, they respond to the gluten casein-free diet in terms of the reduction of permeability, and they have elevated zonulin levels, but they are not celiac patients. That means that the change comes from the community of microbial pattern of the intestine. You see, this is this slide show how autistic have a different microbiota pattern compared to healthy cons. And that means that the changing of the environment in this kind of patient is really the microbiota. When in the past was tried the transfer microbiota therapy, I think was an important improvement in terms of possibility of treatment of this disease. In any case, unfortunately, the treatment doesn't last a lot, and so we have to find different way to introduce bacteria inside the bowel to have a stable answer in terms of behavior or gastrointestinal symptoms. So the evidence that we have now are that microbiota can influence many chronic, non-infective inflammatory disease. And gut microbiota, we know that is involved in many other diseases where you can find clinical sign or biochemical sign to understand or rapidly understand the kind of interaction. But now we are able to say that even autism and, for example, hepatic encephalopathy are even pathology where gut microbiota has an important interference. And the microbiota, we can say that's very fragile at the very beginning, because you can see how many steps can interfere on microbiota growing. That means that this part of the early life is crucial for the beginning of certain inflammatory diseases. And if it's true, that's why pediatricians are very concerned for the first 1,000 of days of life, because these days are crucial for our clinical destiny. That means that many factors can interfere with the growing up of the right microbiota and then to develop of many inflammatory disease. In our outpatient clinic, we collected the information about 900 patients that were coming in our clinic. And if you see, a lot of them, they have signs just from the medical history of something that was able to interact that fragile environment of the microbiota from the very beginning. For example, the family history of autoimmune disease and irritable bowel syndrome was very common, 35%. A cesarean delivery complicated pregnancy was present in the 63% of the patient. The feeding or weaning complication were present in 82%. And the early use in the first year of age of antibiotic was very high, 41%. Or the presence of an acute infective event in the first year of age was in the 38%. And behavioral disturbance emerging after gastrointestinal development was in 88%. So a big amount of patients, they showed symptoms before the development of the autistic syndrome. So the old term of dysbiosis, that's a microbial imbalance, I think has to be changed in pathological gut dysbiosis, just for clinicians to better make a difference between level of dysbiosis and different degrees of dysbiosis able to induce different degrees of inflammation. This is something that needs to be studied and needs to be taken in our culture, because I think it's something very important. And in this paper on ankylosing spondylitis has been shown how dysbiosis is able to upregulate zonulin release, and then how zonulin is a trigger of the inflammation for this kind of disease. For this reason, the environmental triggers causing zonulin release is not just gluten, but even the gut microbiota. And so you can, in this complicated algorithm, you can see on the prenatal, perinatal, and postnatal how many different things can interact on the growing up of the microbiota, and how the dysbiosis that can be how this is able to interact with zonulin and then exert an action for the inflammation of the permeability of the bowel. So going on my conclusion in this talk, I would like to underline the autistic, for me, IBD paradigm, because if we are normally used to face Crohn's ulcerative colitis, where the inflammation is normal in the mucosal layer, and so the symptoms are more diarrhea and blood, and the inflammatory index are very high, while the abdominal pain doesn't follow in the same rate with the inflammatory index. And so Crohn's and ulcerative colitis are in a certain way easy to be diagnosed. The autistic IBD, the inflammation of the serosal and muscles layer, that means here where you have the muscle for the movement of the bowel, or the serosal where you have the nervous system, means that this patient, they have more pain, more extraintestinal symptoms, and less inflammatory index. This is important because here is very easy to make diagnosis for an intestinal disease. Here is very, very complicated. You have to perform an endoscopy, you have to study the patient, you have to see them, and you have to try to understand their behavior, to understand their symptoms. So I think we have to go back to the past, where the visit, talk with the parents, talk with the mother, see the patient is now mandatory to better understand this very complicated intestinal disease. And it's crucial to make a sort of team, I mean, to collaborate with different specialists in the way to understand better how microbiota is crucial in the development of this disease. And the better knowledge of the microbiota, I think, will permit its therapeutic use in many different inflammatory bowel diseases. And for this reason, we need to study the changing of the microbiota in every single patient during the first time of the birth. I think it's not necessary now to continue to study the microbiota condition in every single disease. This is the only way, I think, to better find when the inflammation will start, and consequent the right timing for the therapy. So in conclusion, gastrointestinal symptoms are present in a high percentage of ASD patients, and they anticipate the onset of the disease. a specific inflammatory disease different than Crohn's disease or ulcerative colitis with eosinophils infiltration was present in the colon in more than 80% of the patients in our study. Eosinophilic infiltration was correlated with MASH 1 or 2 status, and dietetic and pharmacological treatment of this intestinal disease showed an improvement of gastrointestinal symptoms, even of the behavior system. The role of dysbiosis on the onset of this inflammatory process through zonal release is crucial in autistic patients, and consider the nervous system involvement as a possible complication of an intestinal inflammatory disease. Consider autism-like and multi-organ disease. And I say that microbiota is now a sort of new common scientific language that will permit a multidisciplinary approach to autism, and consider the importance of gastrointestinal symptoms in patients with higher threshold of pain and with the absence of verbal communication. Consider the opinion of parents and their effort to better understand this complex disease. Consider a patient with autism like every other patient. So I conclude with this phrase of Schopenhauer that I think is very actual in even medical position. And I thank you for the attention, and thank you very much.
Thank you very much, Dr. Balzola. We started a few minutes late, so we'll go ahead and take a couple questions. One question we have for you is, in your biopsies, did you see changes in the gut-associated lymphatics? What were those changes, and was there a change in the lymphocyte populations?
So we didn't perform this kind of study, I'm sorry. So the only information that we have is that a chronic different inflammation than Crohn's disease and ulcerative colitis. We got all the biopsy, and we are going to perform this study in the near future.
Okay, thank you. And one other question. Can you please share your view on SIBO, that's small intestinal bowel overgrowth, and autism kids who do very poorly on fermented foods, usually exhibiting severe neuropsychiatric behaviors very rapidly with exposure to fermented foods?
Yeah, that's true, but the problem is very complicated to have data about the SIBO, because to perform the test is really, really complicated. But I agree with you. I think that's the main point.
Okay. Do we have any other questions from the audience for Dr. Balzola?
There's one more on your chat.
Can you read it?
Do you feel microbiota transfer, such as done for CDI, may be warranted in ASD patients who are gastrointestinally asymptomatic but test positive on Clostridium toxin A and B?
Oh, that's a very complicated question. My experience on fecal transplant is not so big, because it is not a tool, a therapeutic tool that we are not using. We are trying. In the future, we probably will use it. My concern on the using of fecal transplant is that we are using a very powerful weapon, and we are not probably enough able to understand all the interaction between the bacteria and the inflammation. So I think the use for fecal transplant needs many more attention and many more peculiar data to use it. I think it's like to drive now a Ferrari, to drive a Ferrari to a child, and he's not able to drive a Ferrari. We got a powerful treatment, and we need to use it very carefully. And so I can't answer why or not is necessary to treat this kind of patient. I think, first of all, we have to understand the use of fecal microbiota transplant better than now, and then to use it. We have to avoid the the mistake we have done with the antibiotics in the past or many other drugs that we used in a widely way as soon as we had the possibility to have it. I think we need to be concerned to the use of fecal transplant in all the patient with not special group and special study or special diseases.